Everybody, it's Tina here again, as promised with my next video. The last video I did was Psych 101, so you might see some repetition going on between today's and that one, but you're going to see a lot of overlapping anyway throughout these teachings because they all eventually come together somehow or another. So today we're going to talk about what I told you was the most popular, for lack of a better word, mental illness, which is depression. And as I told you, about 3 million people suffer from depression. What is depression? You know, I'm going to have to refer to my notes here and there. So again, if you see me look away, it's because I'm looking at my notes. But it's not the case of everyone feeling blue. It's not, it's a common but serious mental illness, if indeed it is true clinical depression and you're not just trying to get over something sad that happened, unless it lingers, and it lingers and lingers, you know. But if you lose somebody to death, of course you're going to feel sad, you're going to feel depressed, you may not want to eat or whatever, but those kind of depressions are not really clinical. So you really want to make sure that you are properly diagnosed, if indeed you are, if you need that help. Many people who have mental illness do not even seek treatment. I can name several people in my family who are untreated depressive or bipolar or schizophrenia, and then I got family who are diagnosed schizophrenia, depression, bipolar, so it could go either way. The different types of depression are major depression, which it's the major depression disorder, MDD. That's the most common of the depressives. It's very serious. These people who have this illness generally have also suicidal ideations. So they have to be watched and monitored really closely and be on the right medication track. And they're so depressed that it interferes with their daily functioning. They can't get up out of bed. They don't take a shower. They don't brush their teeth. They really don't care how they look or whatever. I mean, it's just they don't care. That's the bottom line. Don't care. You know, and we want them to care about a lot of that stuff. Some of it's irrelevant and superficial, but some of it is really things you need to concentrate on, like good hygiene. The way they treat major depression is the way they treat most depressions, which is with different types of what they call antidepressants. There's a bunch of psychotropic medications. The ones for depression are called antidepressants. And so you and your doctor will sit down, discuss your symptoms, discuss your feelings, and he or she will get to the root and hopefully get you a good cocktail of medication that's going to work. Because to be honest with you, sometimes people need several medication adjustments before they got the best combination that works for them. There are no two people that are alike. So what works for me is not going to work for you, or it could, but it could not. I mean, and then you got one doctor who says, no, you need to be on Abilify, figure a way to afford it. And then you have another doctor who's like, oh, forget Abilify, let's put you on some Seroquel. You know, so it just really matters where you go, where you get your treatment and all that. And they need to monitor you. They need to make sure that you're taking your medicines as prescribed and meeting your appointments. Whether there's therapy involved or not, you will still have medication monitoring. Excuse me, itchy right here. You still will have medication monitoring with the psychiatrist. Okay. Another type is persistent depressive disorder, and I haven't heard that in a long time. So basically, it's depressed mood that lasts at least 2 years. A person diagnosed with this may have episodes of major depression, along with periods of less severe symptoms. So they're not always having the symptoms, but they'll have them for at least 2 years, and then maybe they'll go 2 years with nothing. Let's see. It does have severe symptoms associated with it, though, when it does have symptoms. But the symptoms must last for at least 2 years. And so if you can go 2 years without any of those symptoms that would qualify you as being depressed. Remember, we talked in the last video about the DSM and the qualifications it takes to be diagnosed. And even though people carry traits, it doesn't mean they necessarily have the illness. Remember that? Well, jumping off of that point is this. This is a criteria under the DSM that says you have to have it for at least 2 years. So I don't think I've ever really run into anybody in my years that had persistent depressive disorder. It was usually major depression, and then they got what they call lighter, not as heavy as major depression, like dysthymia, which is a low-level depression that you've had over time, so. But I had never heard of persistent. I haven't met anybody yet with this disorder that I can remember anyway. It's been a long years. Some forms of depression, psychotic depression. Now, when you hear the word psychotic, what do you think of? Yes, like schizophrenia or something like that. But psychoses have to do with hallucinations, paranoid delusions, impaired cognitive thinking, stuff like that. So if they are psychotically depressed, they're not only showing symptoms of depression, but they are also showing symptoms of a psychotic disease. Postpartum depression. That's a familiar one to all you moms out there, right? That happens very often. Some people get it way worse than others, but it's just like with any illness. There's going to be more severe cases than not in every diagnosis. There's some people who have the very extreme and some who have the very, very mild. This is just a little bit more than just I got the baby blues, and just kind of, postpartum is a diagnosable and treatable disease. 10 to 15% of women experience postpartum depression. There's also something called, and I learned this about 20 years ago, and it was so interesting. But there's something called seasonal affective disorder. So basically, you're depressed during the fall months or when there's no sunlight, basically. It could even be the summer, but maybe it's a rainy day or something, and it's real dark outside. But you respond to that lack of light in your life, so you start to have depressive symptoms associated with darkness. So once you get back out into the light, sounds kind of funny, walk to the light. Once you get they actually treat this with light therapy, but that they'll also throw in some antidepressants if needed. There's really not much, it just really depends on how it hits you. And I'm looking at my notes, and it's just through the winter months and when there is less natural sunlight. So, they may be treated with light therapy, but nearly 1/2 of those with this disease don't get better with just the medications. With therapy alone, they need antidepressant medication. Okay, the bottom line with this one is, what this is telling me is that 3 modalities of treatment need to happen with this type of depression. 1, exposure to sunlight. 2, antidepressants. And 3, psychotherapy. So that's what needs to happen there. Now, people always want to know, what causes mental illness? I have a big family, and why am I diagnosed with an illness when everybody else isn't, or something? I mean, we all grew up the same, we all got the same genetics, whatever. It's just the luck of the draw. I mean, really, the causes I have listed are, yes, genetics play a part. So if you have a family member, especially a blood sibling or mother or father, then you will have a better chance. You are what we call, what's that word? Oh, whatever. I can't think of the word. But you are more inclined to get a diagnosis of some kind of mental health disorder. Let's see. Some other causes that they think cause depression is a combination of genetic, biological, environmental, and psychosocial factors. And remember our last video, we talked about psychosocial stressors and the axes diagnosis. Psychosocial is number 4, and that's the one where you list what kind of environment they are existing in, what kind of environment are they living in, and what type of support system do they have, what type of financial assistance do they have. I mean, you just look at all that, and that is they plays a big part in it. Predisposition, that was the word I couldn't remember. Some people have a predisposition to mental illness because of the genetics. Doesn't mean they're always going to get it. Doesn't mean they're going to get it when it's textbook time to be diagnosed. But they could end up with it later in life if it doesn't show its face early in life, or they may not end up with it at all. But it's a combination of things. It's genetics, it's your environment, it's what kind of stress level are you under. Stress is really a serious thing. People just they go around saying, hey, I'm stressed, but true stress, that's rising your heartbeat and rising your blood pressure and doing that kind of stuff, that's very serious stress that can cause you to have a heart attack or some kind of heart malfunction. And it could cause you to be depressed because you hate getting up every day and dealing with whatever it is that you're dealing with that's got you feeling depressed in the first place. So it's like a cycle, a circle. Now remember, all these depressions are all Axis 1 diagnoses. And if you remember from our last video, Axis 1 is organic chemical disorders in the brain. It impairs thinking, judgment, and behavior. So it will be on Axis 1. It'll be treated accordingly depending on which medication works for you. I mean, you might try 10 before one finally agrees with you and you're like, hey, I'm feeling better now, after months of feeling crappy, even with the medication that they prescribed. Make sure you find, when you do find if you need a therapist or a psychiatrist. God, I can't think. I've been up since 6, getting ready to hit the streets. Be very careful, attentive, and care about who you have as your psychiatrist and your therapist. Make sure they seem to have a true investment in your recovery. Now, when I say recovery, a lot of people always associate that with alcohol and drugs, and that's just not the case. Mental health uses the word recovery to recover from mental illness. Doesn't mean there's a cure, because there is no cures for mental illness. There isn't. All you can do is manage your symptoms and do your best at being a productive member of society, and hopefully you are, but if you need the help, make sure you really get with someone who's invested in you. Don't go to those guys who are like, set you up for a 1 o'clock appointment, and by 4 o'clock you're being called in and you only sit 5 minutes with him. So you wait 3 hours to see him, and then you spend a whole 5 minutes with him, and he doesn't listen to what you have to say or any concerns or behaviors you've had that are not normal for you. I had that happen before to a friend of mine, and it was just like, new doctor. Found a great new doctor. They're there. You just got to look for them. Signs and symptoms. Signs and symptoms. Now, again, on the other video, I went over some signs and symptoms of depression when we talked a little bit about suicide and stuff like that. And I am going to do a whole video on just suicide alone. But I've just been giving you guys little tidbits here and there so that you can, if you're going through something now, you can go ahead and take action. But I am going to do something on suicide. There's a lot to learn about suicide. But anyway, signs and symptoms you need to look out for: persistent sadness, anxiety, or feeling empty, feelings of hopelessness, helplessness, pessimistic, guilt, worthlessness, irritability, restlessness, loss of interest in doing activities that you really used to enjoy doing, including sex. People with this oftentimes don't want to have sex. They don't feel pretty, they don't feel desired, they feel hopeless, helpless, and they're not going to be having sex with you if they're feeling that bad about themselves. So that is a true symptom. Overeating or loss of appetite, I talked about that in the last video. Fatigue and decreased energy. They want to stay in bed all the time or on the couch all the time, and you're trying to get them out and get going, but it's really, really hard for someone with depression to just snap in your back, being who you were 20 years ago or whatever. It takes steps. It takes a support system, and the support system includes your family, your doctor, your therapist, and your very close friends, people you can trust. Keep your circle small. Keep it close, because there are some people who may pretend to be your friend, but are really just looking for things to say about you to others. So keep your circle tight. Got that? Good. Other things are they can't concentrate. That's why I said it's a cognitive impairment. Thinking, they can't think. It's just they're racing thoughts, or they can't remember things. They forget things. Aches and pains. Now this one's interesting because a lot of people don't associate aches and pains with a mental illness, but depression and bipolar are two diseases that actually manifest physical symptoms. Your body really hurts. So that's why a lot of the new medications that they're coming out with are also like Cymbalta. They are it addresses depression, but it also is good for like fibromyalgia or any kind of other pain you got going on related to your illness. That's one of the ones they're using. I mean, it doesn't work on everybody, and you may never be 100% like you were before, but you could get as close to it as you want to, depending on how detailed and determined you are to get back to a good place in your life. Okay? It can also cause digestive problems, diarrhea, constipation. Stress does that to people, so if you're stressing out over your illness and stuff like that, it's really going to affect you down digestion too. Who is at risk? You are. Can you see me pointing? I'm pointing. There we go. You are. Everybody is. Okay, bottom line, everybody is. Major depressive disorder is one of the most common mental disorders in the U.S. We talked about that last video, and we're talking about it again. It takes up a large percentage, and then if you remember correctly, it was in the billions that is lost every year at jobs and companies and stuff, and for people with mental illness because they're not producing at their maximum potential. So about 6.7% of U.S. adults experience major depressive disorder. That's just in the United States. Women, and we talked about this last video too, women are 70% more likely than men to experience major depressive disorder. Non-Hispanic blacks are 40% less likely than non-Hispanic whites to experience depression during their lifetime. Did you get that? Okay. The average, and I underlined average for a reason, the average age of onset for major depressive disorder is 32 years old. According to my sources. Additionally, 3.3% ages 13 to 18 have experienced a seriously debilitating depressive disorder. Now, why did I underline that, you ask? I underline it because I mentioned in the last video that people between the ages of 18 to 25 is when they have their quote-unquote break. So, but I also hope I made it clear on the last video, and if I didn't, I'm going to do it now, that there's always an exception to the rule. Yes, that's mostly when people break, so, you can kind of gauge it, but we got adolescent psychiatry, pediatric psychology, adult psychology, senior psychology. So, the field takes care of everybody, all ages. What I wanted to say is about women. I think that a lot of that percentage, them having such a high percentage, is, like I told you, they're the most. They're the most that are going to try to commit suicide, but not succeed, as well as a man who tried to commit suicide. Women try more. Men accomplish it better. Let's see. Oh, the average. That's what I was saying. The average is because like I said, I wanted to make it clear that some textbooks and stuff will say 18 to 25 years old, and that's how I was educated. That's how I was educated in school, was 18 to 25. But as I was working more and more into the field, I started to see acute patients with new diagnoses at older ages. So this makes sense to me, I didn't learn that in school, but hearing it now, and then deducing all my experience, I can believe it. Yeah, so treatments for depression. Even the most severe cases can be effectively treated. So there's no lost cause, or there's no hope. There's always something to treat somebody somewhere. The earlier, this is important, it's just like cancer. The earlier the detection, the better your chances of getting back to the way you used to be before you got sick. Because this is a true illness, like I've told you before. Mental illness is real. It is true. It is, if they are truly mentally ill, they are not making the choice to do, behave, and all that, or whatever they're doing. And if it irritates you, you need to understand they're not intentionally doing it unless they're just brats and they're not really mentally ill. I mean, and that goes for adults too when I say brats. I don't want to pick on just the children. Let's see, but it increases the success rate. The sooner you catch it, the sooner you'll increase your rate of succession, of succeeding. You have to go to a specialist, and like I said, what I was saying a little bit earlier, make sure you pick a good one. And I'll tell you, if you go see him or her and you tell them your whole story and they don't seem interested, or they don't seem like they want you back so they could help you, move on. Do not waste your time going to a place that in your first visit you didn't even feel a difference. It could be the tiniest little difference, but like a glimmer of hope maybe, and if they don't even give that to you, move on. Find somebody else, because there's plenty of people who will give you that little glimmer of hope on the first visit. Treatment, and they'll set up treatment plans for you and who you're going to see and how often and what meds you're going to take and how often and all that. So keep that in mind. Make sure you're honest with your therapist and your psychiatrist. A lot of people like to hide things. They hide the fact that they've been using drugs or whatever. They hide the fact that they haven't been eating, or that there's no problems. Basically, they're acting like everything's fine. I'm fine, doctor, I'm fine. And that's not the truth. I mean, you could get some really weird thoughts in your head, but be afraid to share them because you're afraid what people are going to say or do. Remember, we talked about that last video, about the stigma associated with mental illness. We need to break that. Together, we can break that. Let's see. Now, remember, if you're diagnosed with depression, alcohol is considered a depressant. So you really should not be drinking alcohol when you're taking antidepressants, or you're depressed, you're clinically depressed or whatever, because all it's going to do is exacerbate your depression. You're going to end up being more depressed, and it might even cause you to do some behaviors you would not normally do if you were not so drunk and depressed and down, like jump off a rooftop. I saw that recently. I went to the funeral of a lovely young girl who did that. Now, I don't know what she was experiencing, but she was 17 years old, ready to graduate, and she decided it would be a good idea in the middle of the night to take the bus to downtown, get up on the driving parking lots, the one they have them, you keep going up. And she went to the very, very top, and she paced for a little while before she finally jumped, and of course immediately died. So I attended her funeral because she was the relative of one of my best friends. And it was just so sad to me. I was just so sad because I thought, what else? I mean, at that time, there was a lot going on for me too, and her, my friend. So we were both having challenges, and we were just trying to keep each other up. Now, people with depression tend to have anxiety. Usually they come together. So sometimes you'll get an anti-anxiety medication, but I can tell you that a lot of psychiatrists do not like to prescribe, can't think of words today, they don't like to prescribe what we call benzodiazepines, which is the Valium family. Valium, so what is it, Valium, Klonopin, those kind of sedate medications, and lorazepam, which is Ativan. Some won't, some will, because you need it. You need it because your anxiety is that bad, but some won't at all. And if you are experiencing severe anxiety, then you need to get out there and find someone who's going to give you an anti-anxiety medication even if it is a benzodiazepine medication, because you need it, and not everybody abuses it. Let's see. Depression, like I said, is usually accompanied by anxiety, but it can also be accompanied by PTSD, or other coexisting disorders like the alcoholism or the drug addiction. So you got to be really careful. You talk to your doctor about what your lifestyle's like, what you want it to be like, and you two work together on that. And if that means you have to stop drinking for a while with your buddies, then do that. Get yourself well first, and then get to the point where, you and Doc might say, yeah, it's okay if you have a couple beers, it's okay as long as you do it between this time and this time, and because it'll react with your medication and make you more depressed, blah, 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 that kind of thing. Antidepressant meds work on brain chemicals. Remember I told you the chemicals in the brain, it's organic. It's called the neurotransmitters. The chemical neurotransmitters in your brain are specifically called serotonin and norepinephrine. Other antidepressants work on the neurotransmitter dopamine. So we know for a fact, science knows that depression is indeed partnered with serotonin and dopamine, and now we know norepinephrine. We always knew something was wacky, something was off there if you were clinically depressed, and the medications that they give you are to fill in those gaps that are not being filled in by your normal neurotransmitters. There are medications that are called the SSRIs, selective serotonin reuptake inhibitors, like Prozac, Zoloft, Lexapro, Paxil, and Celexa. These are the most common ones they'll use. Doesn't mean that they're going to use them. I'm just saying these are the most common ones that doctors are using at this time. The SNRIs, which is serotonin and norepinephrine reuptake inhibitors, are similar to the SSRIs and include Effexor and Cymbalta. Remember, Cymbalta was the one I brought up a little bit ago, that if you're having pain in your body and you have a depressive symptom, some doctors believe that it takes care of both, and it has been successful for some people on some kind of level. Though the depression is milder, it doesn't mean it's gone away, but it's milder, or the pain in the body's gone away, or it's going away. Because it takes a while for the medications to fully work. We're looking at 4 to 6 weeks, although most people start to feel different much sooner than that, or feel better or worse before that. It really takes about that long for the medication to work. So you have to be patient, because if you don't give it the right time, then you're cheating yourself, because that could be the perfect medication for you, but you didn't give it the time needed to see for sure before you jumped onto another medication. And a lot of doctors will tell you that. You got to give it time. So just remember that. And for all those ones that I named, some of them are really expensive medications, but they have generic forms. So usually you can get a generic form for a pretty decent price. I get the generics whenever possible. I don't care what medication it is, except unless doctor says you have to have name brand. The SNRIs and the SSRIs, what we were just talking about, the reason they're being used more, because there's medications they've been using for 50, 100 years, whatever. But these are newer ones that have less side effects than the older medications. And a lot of the older medications used to cause what we call tardive dyskinesia, and it's you moving, like you can't regulate your body. Your hands are shaking. Your tongue might be coming out of your mouth by itself. You're smacking. You're shuffling when you walk. And I'll tell you, those are all irreversible. You can't reverse any of those once you get them. So like the old medications they used to have, the Haldols and whatever, they don't really give those out anymore. It's really extreme cases if they do, because the side effects, the benefit does not outweigh the side effects. That's what I was trying to say. Some side effects you can look for with these medicines is headaches, nausea, jitters, insomnia, and problems with sexuality. Problems sexually, I should say, not with your sexuality, but sexually. You're just either not going to be into it when you're doing it, or you just don't want to do it at all, until you feel better. So hopefully, if you're in a committed relationship, your partner will understand and support you through this as you work on recovering. So, one popular antidepressant that works on the dopamine in your brain is Wellbutrin. And the funny thing about Wellbutrin, and I don't know if they're still doing this, but I'd say about 13, 14 years ago, they were using Wellbutrin also as a stop smoking aid. It was somehow working for people, because a lot of people with mental illness smoke cigarettes. Some smoke other things, but a lot of them smoke cigarettes. Addicts are addicts. They smoke cigarettes. So when they were giving them Wellbutrin for their depression, it turned out that it was also helping them quit smoking. So some of them were being prescribed that for to be able to be a non-smoker. I don't know if it still works. I tried it, and it didn't work on me, and that was 13, 14 years ago. I don't know. It's still out there, though. That's why I bring it up. But the Wellbutrin, the dopamine-related one, is less likely to influence your sexual activity. So you might be more inclined to be sexual with your partner if you were taking this medication. But again, it's hard to tell. You have to wait and see what you and your doctor come up with. What's your entire treatment plan? How often are you going to see him? Every month, every 3 months, which is basically maintenance every 3 months. Every month is he wants to see you because you have symptoms that need to be monitored a little more closely. And are you going to see a therapist also? So you're going to sit and discuss for 55 minutes what's going on in your life and any troubles that you might have. It's extremely helpful, by the way. I got a lot of friends who are therapists. Let's see. Tricyclics. This is old. This is what I was talking about a minute ago. This is the older antidepressants. Extremely powerful. And that's why they would give those side effects like the tardive dyskinesia and stuff, because they were very potent. But they're not used as much because the signs, and again, like I said, the signs and symptoms of that medication is not worth it. Their illness is outweighed by the side effects and the symptoms. So then that's when they need to look at something else. I haven't really seen anybody, I haven't seen anybody given Wellbutrin in a long time. But it's still out there. I really want to let you know it's still out there. It's still possible to get it. Now, the tricyclics, it's TRICYCLICS. It may affect your heart. You could have heart problems, cause dizziness, drowsiness, dry mouth, and weight gain. And two medications that are included in that also are imipramine and nortriptyline. So there's that. Monoamine oxidase inhibitors, or how we call them, MAOIs, are the oldest class of antidepressant meds, basically used for atypical depression. It helps you if you have like a increased appetite and a need for sleep rather than decreased appetite and more sleep. Does that make sense? They may also help with anxious feelings or panic and other specific symptoms. So the MAOIs, I should say, are really good, but then you got to look at the side effects and your overall physical health too, not just your mental health, because you don't want things, if you're taking medications from a primary care physician, family health doctor, and then you go and you start taking these psychiatric medicines and you didn't communicate to each one of them that you were taking meds from the other, so you could get some really bad effects. So please make sure you're letting all your doctors know all medications you are on. I never go to my doctor's appointment without a list of my medications. Couldn't remember them all, even if I did forget. Let's see, what else? However, people who take MAOIs must avoid certain foods and beverages, including cheese and red wine. Why they chose cheese and red wine as an example, I don't know. But cheese and red wine, they contain a substance called tyramine. Maybe that's why they chose it. Makes sense, right? Yeah. And certain other medications, like over-the-counter cold and flu medications and allergy medications and stuff, can contraindicate with this medication. And what contraindicate means is it's working against that medication. So that medication isn't even helping you because you are taking something else that's like kicking it out of the way, making it not work, or making you sick, physically sick, mentally sick, both. You can be both, And basically it can cause a very dangerous high blood pressure. You don't want that. You do not want that. MAOIs can also react with SSRIs. Remember we talked about the SSRIs to produce serious condition called serotonin syndrome, which can cause confusion, hallucinations, increased sweating, muscle stiffness, seizures, changes in blood pressure or heart rhythm, or other potentially life-threatening conditions. So you can see it's nothing to play with. It's not. MAOIs should not be taken with SSRIs. So if you're taking a medicine from one group, you shouldn't be taking medicine from the other group because they will contraindicate and you will get very sick, very sick. Antidepressants must be taken, like I said, up to 4 to 6 weeks for you to get the full effect. I mean, a lot of people start feeling better after a couple of weeks or a month. They're like, well, a month is 4 weeks. Well, some people will start feeling slowly better. Okay, I'm not too tired. I could get up and do the dishes, or I could put on some makeup and, go have lunch with my girlfriend, or whatever the case may be. And that's good. You're slowly working towards progress. Let's see. Now, remember, this is a lifelong commitment treatment. When you're diagnosed with a mental illness, you are never going to get rid of it. There is no cure for mental illnesses. There's only treatments. And if you do not follow your treatment regimen and the rules or whatever that you've been given by your doctors, tell you do this, do that, do this, do that, take this then, take this then. If you don't do that, you're going to fail miserably. And it won't be anybody's fault but yours. Because you're making the choice to not get help. Now, a lot of people believe they don't need to get help. That's different. If you already know you're mentally ill because you've been diagnosed in the past, and then a few years goes by and you're not taking medications and you're feeling okay, and then this, what good does that do to you? You're not going to be able to hold a job. You'll probably be getting in fights with people because you're going to be irritable and stuff. So you really got to commit to the recovery. Reach for your full potential. And if that means taking medications and seeing a psychotherapist, to discuss what kind of things you need to get off your chest that can help you feel more relieved, things you've been holding in since childhood, whatever, it has been proven that psychotropic medication, in this case antidepressants, and therapy have the highest success rates when done together. If you just do one, you might be just getting by okay and everything. But if you're not doing them, if you're doing therapy without meds, that's not going to work. I can tell you that right now. If you're truly mentally ill and all you're doing is therapy, they will recommend you get put on medication, the therapist. So they do go together. They work together. They come up with your treatment plan together, and they share concerns and achievements and things like that with each other. So it's good to have both if you have the option. Now, I want to say this real quick because it just hit my head when I said option, if you have the option, because a lot of people don't have health insurance. Well, I don't know, but I think Obamacare might cover it. But even if they don't, forget about Obamacare if you don't want to even get involved in that. Most major medical insurances cover mental health. State ones, like if you're in the military, TRICARE, and Medicare, Medicaid, those are all insurances you can use to get help. Now, if you don't have any of those, then the government, whether it's county or state, will give money to a business, a mental health organization that is state funded or something for people who don't have the means to make payments, or if they need payment arrangements, they can do that. We have here in our town, we have one of the top hospitals in the nation, and that is one of the government funded ones. They'll see anybody whether you have the money or not. They'll see you. Most hospitals will do that anyway. They will see you. But if they can't do anything for you, then they'll transfer you to someone who can. So it's real important about that. The national, and on my last video, I talked about the National Institute of Mental Health. Well, they do research. They have funded research. They get grants and they have money to do research. And some recent research has shown that people who did not get well after taking a first medication increases the chances of beating depression after switch to a different med or added another medication to their existing one. So there you go. I just said, if it's not working, how many med adjustments are you going to need? We don't know. It depends on you. It depends on your body. How are you responding to the medications that they've given you? Do they have to relook at the medications and prescribe you something else? So it's really it's between you and you need to be a part of your treatment plan. You need to speak up. Don't be a shrinking violet. You need to speak up for yourself too. Sometimes stimulants, anti-anxiety meds, or other meds are used in conjunction with antidepressant. And that's not, especially if the person has a coexisting illness. Now, we've talked about that too. A little bit today and then on the last video, but if someone has a coexisting disorder, that means that they have a mental illness in addition to a drug addiction or alcohol addiction, or they could be mentally ill and mentally retarded, and be alcoholics and do drugs. It's just, it's just, there's just so many ways it can go. But just know that somebody who's severely depressed is probably not going to just be on just one medication. They're probably going to be on a few of them, because they need to counter and work together. Take care of the anxiety, take care of the crying and the sadness and all that. Give you the motivation to get out there and live again. That all takes time and treatment and commitment. You have to commit to recovery. Can't say that enough. And you always want to make sure, as a partner in your treatment plan, because that's what I'm going to refer to you guys as, you need to let the doctor and the therapist and anybody else who's involved in your treatment know that if you're having any problems with the medications that you're on, any side effects, because you don't want to die from something that's supposed to help you, and your body may have just went wacko when it wouldn't have before, but you're older or whatever the case may be, and your body's changed. So please talk it over with your doctors. The FDA warning on antidepressants, I have to read some of this. In 2004, it conducted a thorough review of published and unpublished controlled clinical trials of antidepressant, controlled clinical trials of antidepressants. I think I just repeated myself. And that involved nearly 4,400 children and adolescents. The review revealed that 4% of those taking antidepressants thought about or attempted suicide, but were not successful. Thank God. And that's compared to the 2% of those receiving placebos. And everybody knows what a placebo is, but if you don't, it's a fake drug basically. It's usually saline or something, but they don't tell you if you're getting the placebo. They just say, we're going to have group A and group B. Group A, you're going to take these. Group B, you're going to take these. And then we're going to monitor y'all's behavior and thinking and stuff. And they might have quizzes to give you or whatever. And, it's just a way of kind of getting away people who are not really truly mentally ill. Because I've seen that too. And then I see our government giving them money through Medicaid and Social Security, and I'm like, no, this person is not really disabled. They're attention seekers. They're personality disorders. They're borderlines. All they want is your attention. Or they're going to carve on themselves or drink some bleach. It's like, ugh. But anyway, where was I? When they got that information in 2004, what they did was in 2005, they adopted what they called a black box. And it's a warning label basically. They have to put it on all antidepressants to alert the public to the potential for increased suicidal thoughts or attempts. And in 2007, the FDA proposed that makers of all antidepressant medicines extend the warning to include young adults up to age 24. A black box warning is the most serious type of warning on prescription drug labeling. I mean, some will say may cause drowsiness, take with food, or take alone, don't take with other meds, or they'll have those kind of little instructions. But if they have a black box warning, you need to really pay heed to that. You really need to pay attention to that, and you and your doctor need to talk about how to not goof up on such a medication. You need to be supervised and monitored, especially initially in the first few weeks of taking new medications. If you're brand new to the field of psychology as a client, then you're definitely going to need to start from the beginning, and you will be seeing people more often in the beginning. And then as you start to get used to your medications and your regimens getting normal and you're feeling pretty good, everything's going good, then they start to slow up the treatment on you and make the appointments farther apart and stuff like that. Let's see. You can also get insomnia, and you can start withdrawing. Now, when you go to like the grocery store or drugstore like Walgreens or something, I'm sure you've all heard of St. John's wort, and that people use it for depression. Some people say it works for them, some say it doesn't. I'm one of those. It does not work on me. I mean, I'm on so many medications, you have to be pretty powerful to make an impact on me. But it's an extract from the herb St. John's wort, and it's been used for centuries in folk and herbal remedies. Today in Europe, it is used exclusively to treat mild to moderate depression. That's kind of scary. Mild I can understand, but moderate, that's kind of scary. However, recent studies have found that St. John's wort is no more effective than a placebo. That's what I said. In treating mild or major depression. In 2000, the FDA issued a public health advisory stating herb may interfere with certain cancers and those used to treat heart disease, depression, seizures, and those used to prevent organ transplant rejection. You got to take certain medicines for all that stuff, and St. John's wort could interfere with that. So if you get a kidney transplant, yeah, that's a good example, kidney transplant, and you're taking medicine so your body doesn't reject the new kidney, and then you go get on some St. John's wort, you're in danger, basically. So don't do that. And always talk to a licensed medical practitioner about the effects of using St. John's wort. If you're insistent on using it and want to stay more natural and less pharmaceutical, talk to your doctors about it, okay? Or your therapist, whatever, whoever's in your life, about giving you your medicines and things like that. Now, psychotherapy, there's two main types of psychotherapies. The cognitive behavioral. Now remember last video we talked about the different schools of thought of psychology. Cognitive was one of them. Behaviorism was one of them. Well, there's actually a psychotherapy regimen for people with mental illness, with depression, and it's cognitive behavioral. So they're using two schools of thoughts to attack this disease. I think that's really cool. If you ever see anything say CBT, that's what it stands for. And interpersonal therapy are effective in dealing with depression. Interpersonal IPT therapy. The CBT, cognitive behavioral, helps with depression, restructure negative thought patterns. Doing so, and in doing so, it helps people interpret their environment and interactions with others in a positive and realistic manner. You need to be realistic about things, you need to be patient about things, and you want to stay as positive as possible. Remember this: life is 10% what happens to you and 90% what you make of it, how you respond to that 10%. Just think about that. Give that some thought. IPT helps people understand and work through troubled relationships. They may cause depression or worsen it. So they're involved with somebody or something, people in their circle that are contributing to the illness. Studies show a combination of antidepressants and therapy increases chances of controlling thoughts and behavior. That's repetition because I just said it. So I read it. It's like I told you. Studies have shown together more effective and a better chance for recovery. ECT and other brain stimulation therapies. Now when you hear ECT, electroconvulsive therapy, what do you think of? I mean, it's like Frankenstein sticking, little metal things on your head and strapping you down to where you're convulsing like if you're having a seizure. It was like that at some point in our history of mental illness. It's horrid. The kind of things they used to do to people with mental illness. They thought they were demonically possessed or something, and these were done all the times, and lobotomies. They were done a lot. So we've come a long way. But in cases where the meds and therapy don't help, ECT may be useful. Before ECT begins, the patient is put under brief anesthesia and given a muscle relaxant. They sleep through the treatment. Actually, they're not awake when they're getting the ECT like they were in the past. So they're not consciously, they don't feel the electrical impulses going in their body. The sessions are very short, and within 1 hour of your session, you should be pretty much back to normal, back to thinking and talking like you normally do. So it doesn't sound that bad. And I worked with clients who've gotten ECT treatments, and I saw brightness to them where there was darkness. I don't know. I'm not advocating for ECT, because to me it kind of feels like being on death row, and they're putting you in the chair and to switch it on. But anyways, it's not like that anymore. It's not that bad anymore. Side effects of ECT, though, remember, everything has side effects. Confusion, disorientation, and temporary memory loss. Usually are short-term, but sometimes they can linger. Research has found that after 1 year of ECT treatments, most patients show no adverse cognitive effects. So that's good. I'm saying even a year later, after the sessions have stopped, it doesn't feel like they lost any important information from their brain. So that's good. There was no cognitive impairment. These methods are not yet commonly. There's a one called vagus nerve stimulation, VNB, and repetitive transcranial magnetic stimulation, small r, big T, big M, big S. These methods are not yet commonly used, but research has suggested that they show promise. So if I hear anything new about it, I'll share it with my viewers. So, but just know that it's out there, and just know that yes, ECT has been back in effect for years. Not everybody needs it or uses it, but it's become more humane, and people are using it. Depression is more common among women than among men. Well, I think we kind of knew that. And in my last video, we talked about that too. Talked about that earlier in this video. And they attribute that to biological, life cycle, hormonal, and psychosocial factors. That's the axis 4 I was talking about. That women experience may be linked to an increase in women's depression. Research has shown that hormones directly affect the brain chemistry that controls emotions and mood. So I'm laughing because I think of all those guys that hide out every 28 days that their woman is on her menstrual cycle because they know how depressed or mean or whatever she can get, and they don't want to be around that, and she's hormonal again. It must be that time of the month. Now, don't always dismiss it as that time of the month because they're hormonal. There's lots of reasons someone could be hormonal, but I just think that was kind of funny. Premenstrual syndrome, or PMS, that's what we were just talking about. Theirs is called PMDD, premenstrual dysphoric disorder, associated with hormonal change that typically occur around ovulation and before the menstruation begins. So we all know what that is. It's just you start getting cramps, headaches, feeling bad, and your period's coming, so you're getting ready for it with your Motrin. Hopefully that'll help you. Something like that will help you. During the transition into menopause, you can also get those signs and symptoms. Some women experience an increased risk of depression as they're going into menopause. Because you got to think about it. Menopause is a very feminine, womanly thing, and a lot of women really rely on their femininity to feel good about themselves and to feel good around others. And if they're going through menopause, they're losing some of that, some of their youth. Their children are getting older. Maybe they're no longer married, but they used to be. So, I mean, a lot of that happens. So it's not just, I mean, your environment plays a big part in it too. They feel excessive guilt. They're more tired, irritable, and loss of interest in once pleasurable activities. Insomnia. They may be more likely than, excuse me, I'm sorry. Here we go. During transition into menopause, some women experience an increased risk of depression. Additionally, osteoporosis, which is bone loss or thinning, may be associated with depression. There's still research being done on this. Other psychosocial stressors may also be a factor to depression, and we talked about that, the axis 4. Now, men's experience with depression is different than women's. Duh. They're more likely to have feelings of sadness. They won't say, I'm really depressed, unless they really are depressed and they're okay with that. But most guys are not okay with sharing their feelings with just anybody. So they feel sad, worthless. A man has to feel like a man. And if anything changes that makes it so he no longer feels that way, it will depress him. Like he was the breadwinner and he got laid off. And now you've had to go to work and he's at home with the kids until he could find another job. And that takes away some of their manliness in their minds. Some minds. Some guys love being house fathers and it works out just fine. But, just letting you know. Excessive guilt over something. They cheat. They're more tired, more irritable, and the loss of interest in once pleasurable activities. And insomnia. They're more likely than women to turn to drugs or alcohol when depressed. So even though women do turn to alcohol and drugs when they're depressed, the men do it way more than women. That's how they hide it and mask it more. So, because women we will usually ask for help. It just depends on the kind of help. But men, I could tell you, my uncles will not go to the hospital unless it's mandatory. I mean, you got cancer or something, you got to go. Otherwise they do not go for regular prostate checks and things like that. And I sat in when I was in psych nurse, I sat in on a prostatectomy. So they were taking out his prostate in front of me and stuff, and all I kept thinking was, is this going to cure him? And I don't know, because I left the surgery early and I went about doing rounds and stuff on other floors, but it was real interesting to see them do a prostatectomy. Depression is, some men throw themselves into work so they don't have to talk about their feelings. They'll just dive right into work and stick to that. And some women do that too. They also may become frustrated, discouraged, irritable, angry, and sometimes abusive. He becomes abusive, you get to going. Because domestic violence is nothing to play around with. And if he's sick, and he's hurting you, he has no business being in your life at all while he's sick. And he should be forced by a restraining order, a judge's order, a doctor's order, something, to get help and seek help and recover and be in recovery with his illness before you and him can start up again, or you and her. But this is guys, but it can happen to girls too, So, like I said in my last video, and I might have said it a little bit earlier, but women attempt suicide more often, but men succeed more often. So women, I think, just do a lot of it for attention seeking. Cutting on their arms, but they're cutting lightly and they're cutting across their arm, knowing that it's the long way, if you cut along your vein, you're definitely going to probably bleed to death, Or if they cut themselves right, they will bleed to death, but they don't do that for for that particular behavior. They'll cut on their legs, they'll cut on their arms, they'll cut where people can't see them. And it says they say it feels better than the pain they're experiencing. I don't know. Never cut on myself on purpose. So that's a behavioral issue. And that goes with the borderline personality disorder that I described to you all in the last video on Axis 2. They're very infamous for doing stuff like that. Getting you to get up in their business because they're going to kill themselves. Again, I'm cutting on myself. Oh, I'm going to drink the bleach, or I'm going to walk in front of a car. Stuff like that. And a lot of it is just attention seeking. I mean, we got to take it seriously, of course, because they might do it not meaning to hurt themselves and end up hurting themselves or killing themselves. So you got to take it seriously no matter what. Older adults experiencing depression, it's a little different. These are seniors. These are our history makers. So first of all, I want to say it has nothing to do with depression, but please treat your elders with respect. These people have made landmark decisions, had landmark decisions made by their generation. And the wisdom that they must carry is just amazing. When I sit and talk to my elder aunt and uncle and how they used to march with Cesar Chavez, because when we all lived in California and stuff like that, and they're still very much a part of politics, Hispanic politics and stuff. But when you hear things like that, I mean, it's really something to be proud of. But depression, you might need to understand. I mean, some people might be getting depressed. I'm getting older. I don't want to get older. And they get real sad and maybe even cry. I don't know. But you should know that depression is not a normal part of the aging process. Whenever seniors are depressed because they may show different, less obvious symptoms. There you go. I finally got that sentence out. I need some caffeine, that's what it is. Grief. That is a complicated and lasts for a very long time. Following a loss may require treatment. If the research is ongoing on that, but if an older person experiences grief and their grief lasts way too long, it's too intense, like they're not eating, they're not sleeping, they're not participating in group or anything, and this goes on for longer than 2 weeks or even a week, something has to be done. Some intervention has to happen to turn that person around, because they took that loss really hard, and at the rate they're going, they'll be joining that loss. So don't want that. Increased physical and medical problems is it's equivalent of depression. Like, the more physical stuff you have wrong with you, the more mental and physical stuff you have wrong with you, the more likely you're going to have a higher level of depression. Or you're just going to have depression, period. Because you have all this medical stuff. I mean, because really, when I was in boot camp for the Marines, they used to tell us all the time, and it's stuck in my head. Everything I learned, even though it was over 20 years ago, I remember. And I learned, and the drill instructors always used to say something so simple, but it made such sense. They would say, if you look good, you feel good. If you feel good, you'll do good. And that was kind of our model of our platoon, And I remember that, and basically they're saying, take pride in your appearance, and you will feel better about yourself. And when people are feeling good about themselves and feeling good about life is good. Their jobs are going well, friendships are going well, maybe romantic relationships are going well, but they have to feel it first. They got to feel good about themselves first. So, vascular depression may result when blood vessels become less flexible and harden over time, becoming constricted. And this is for aging people. Those with this kind of vascular depression may have or be at risk for coexisting heart disease or stroke. That's kind of scary. That's pretty scary, that you have this vascular depression that's actually physically working through your vascular system to make you depressed, and then it triples or doubles or whatever your chance of getting a heart attack or a stroke. That's kind of scary. That's really scary. Older white males, this I found so interesting. Older white males ages 85 and older actually have the highest suicide rate in the whole United States. 85 and older. Can you believe that? I mean, you're thinking you hear about all these kids killing themselves and things like that, but yet all the professionals in the field that are studying this and stuff determine that it's men over 85 and older that have the highest risk of suicide. It doesn't surprise me. I just find it fascinating because I can see why somebody would. Say you were married for 50 years and your partner passed away, or you're suddenly homeless, or your partner is sick with Alzheimer's or dementia, doesn't remember you, or you're feeling guilty about something you did in your younger years and it's catching up to you. You never know. So just be prepared. Okay, children with depression. Not quite the same. Children who develop depression often continue to have episodes as they enter adulthood. Signs and symptoms and acts. They act sick. They don't want to go to school. I don't feel good. I'm sick. They refuse to go, or they just plain out refuse to go. They're negative. They misunderstood. Their grades are negatively affected. And see, by age 15, however, girls are twice as likely as boys to have had a major depressive episode. Well, if you're a girl, you know that. You get it. You got the hormones. You got the, it's going to happen. It's just, yeah. The most effective treatment is meds and therapy. Like I said, the National Institute for Mental Health is always testing ways to prevent suicide in children and adolescents. I think that is cool as hell, that they are actually working on ways to prevent it. So that means they're going to find a way to be able to detect it in a child and say, yep, this person has the chemical compilation to be major depressed and will probably be when they grow up. But we can stop it, and we're going to stop it now, so he'll never get to that point. If we can get to that point in mental health, Jesus H, that is just like a major, huge accomplishment. So, how can you help? What if you know somebody who's sick mentally? How can you help? Well, you can offer emotional support, understanding, patience, lots of patience. Because you're going to have back and forth with that person. Yes, I'm feeling good. No, I'm not feeling so good. I'm sorry, we were supposed to go, but I can't go. That kind of thing. And encouragement. Never dismiss the feelings. Like I told you in the last video, even if they're joking or they're saying it in a joking manner, don't take it lightly. This is very serious. And point out realities and offer hope. Don't make realistic expectations. Don't make them so high that they're unachievable. Start low, achieve that, then go to the next one, achieve that, and that way they're feeling the progress. They're feeling like, hey, I'm getting somewhere, Never ignore comments, like I said, about suicidal, and report that the person is suicidal to the loved ones, and especially the doctor. Now, there are what we call HIPAA rules, and anybody who's been to a doctor's heard of it. It's been around for years. Now, because of HIPAA, you may not be able to get information from their treating physician or therapist, but you can give information about them to them, and they won't mention anything to you about that person. They'll just say, okay, well, thank you for the information, and then they'll work it into the treatment plan with the person. So don't feel like, oh, well, they're not going to give me authorization to speak. No, you don't need to have authorization to speak. It'd be good if you did, if you're going to be their primary support system. But if you're not, and you're just concerned, then you can just call them and say, hey, I'm so-and-so, friend of so-and-so, cousin of so-and-so. This is what's going on. I'm worried, and please just report it. That's the bottom line. I can act out a whole scene of it for you if you want me to, but I'm not going to. This video is long enough as it is. Depression is, when I took on depression to make this video, the research I did on it, it was amazing to me how much is out there and how much has been born since I first went to school and was doing all this. There's been strides, but luckily I've kept myself in the psychology loop all these years, whether I was actually holding a position in it or not. So, other things you can do is you can invite your loved ones out for walks, outings, and other activities, things they like to do. Keep trying, but if he or she declines, don't be pushy. It has to be on their time. Don't let them go too long, but it has to be on their time. You don't want to do too much too soon. Provide assistance in getting to doctor's appointments. If you can drive someone there, they don't have a car, or they would like you to go for emotional support, and you can do it, do it. I know people work and stuff, and sometimes it's just not, you can't, but do what you can. There are things that can be done. Remind your loved one that every time and treat the depression. Okay, I can't remember my own notes. Basically, what I'm saying there is that you want to remind them at all times that they're loved and they're important to you, and whatever concerns you might have or whatever, and that there is a silver lining at the end of all this. There is some light at the end of the darkness. These people who truly, truly care about you are going to grab your hand and pull you out into the light, out of your darkness. So you keep letting them know things like that and being there for them and all these other things I talked about, and you'll be amazed at how much of a difference it could make in someone's recovery. Now, help yourself. Now, what if you're a person who you think has depression, or you have depression? Okay? Help yourself. Do not wait too long to get evaluated or treated. There is research showing the longer one waits, the greater the impairment can be down the road. That's what I meant to say. If you catch it soon enough, like cancer, you can pretty much take care of it. If you let it go on, like cancer, it's only going to get worse. That's what I'm trying to say. See a professional ASAP. Try to be active and exercise. Go to a movie, ball game, or other events you enjoy. And the one thing about the exercise and being active, that's not just good for mental illness, it's good for your whole body. Your circulation, your heartbeat, and some brain transmitters. You can get a euphoric brain reaction to an exercise class or something. You get into it and you start feeling happy and you're like, yeah, I can do this. And that's how people get successful, because they feel so good, they don't stop. So, let's see. Set realistic goals. We talked about that. Break up large tasks into smaller ones. Set some priorities and do what you can when you can. I just said that a little bit ago, so. Try to spend time with other people and confide in a trusted friend. Not every friend is trusted, and not everybody you trust is a friend. Or a relative. Try not to isolate yourself. Oh, that's so easy to do. And sometimes it feels like the right thing to do, just to lay on the couch and watch movies, or lay in bed and watch TV, or whatever the case may be, listening to music, but you're laying down doing nothing. It's so easy to do. So when you get up and you're actually doing stuff, you need to give yourself a little pat on the back and hey, congratulations, girl, you did it. You got up today. Make them realistic. To go day by day. Write a journal. Use a journal. Today, these are my plans, and then what I did, and then at the end, did I accomplish what I set out to do early in the morning? That would be a great journal for you. That's not on my notes, but I know well about journaling. Expect your mood to improve gradually. Gradually. I tell you, I need caffeine. Expect your mood to improve gradually, not immediately. And that's the 4 to 6 week thing I was talking about, in possible med management that's going to need to happen several times before you get the combination of medications that works just for you and your illness. Do not expect to suddenly snap out of it. You're not gonna. Your depression, sleep and hunger should improve. Postpone important decisions such as getting married or divorced, changing jobs, until you feel better. But basically, talk to your loved ones about it, especially if you have a partner in your life that you love. Single, straight, gay, bi, transgender, I don't care who you are. If you have a loved one, please include them in your therapy. If they are truly your love partner, you want them included in your therapy and your treatment and I keep losing words in my head. Recovery. God, that's what I was trying to say, recovery. You want them included in every step of your recovery, okay? Remember that positive thinking will replace negative thoughts as your depression responds to treatment. So as you are more and more into your treatment, you'll start to be thinking better thoughts than you were thinking before treatment. And you really, the bottom line, continue to educate yourself on depression if that is indeed what you have, or someone you know has it, or someone you love has it. Stay educated on it and make sure they're getting the right dosage of medications, that they're not being doped out, or they're not getting enough, or they're not getting what they need, and what they're taking is not working and the doctor's not cooperating. You really got to be on them. You got to just be proactive and stay with your appointments and you are the main person of your treatment plan. So you kind of call the shots. You know what I mean? So now here's just some FYIs. If you're ever interested in doing clinical trials, that's these commercials you see. You can get money for going to do clinical trials. There's one called clinicaltrials.gov, and they do different kinds. You can go to that website. They do different kinds of trials. Now, whether they all pay or not, I don't know. I didn't go to the site. I'm just providing it to you all because we have a lot of that going on here. This is a very medical town. We're a big military town, but we're also a big medical town, and a lot of that has to do with the military. So, but you can get another way is a medical alert bracelet. So if you're by yourself or whatever, you could press it and get the help you need. If you're alone a lot or you live alone. And if people don't really come over, then you're going to need some way to quickly contact help. Oh my God, I feel like I'm going to kill myself. Oh my God, click. What's going on? This is what's going on. So there you do that. The suicide prevention hotline I didn't have it in my last video, but one of my good friends, Terry, put it down in comments. So I'm going to give it to you right now again. It's 1-800-273-TALK, TALK, TALK, or 1-800-273-8255. If you want to do by text, you text listen, the word listen, to 741-741. The Trevor Project can be reached at 1-866-488-7386. Now, the Trevor Project is a little bit more geared towards the LGBT community, but I doubt they're going to hang up on you if you call them. But they're really there because a lot of children or teenagers or adults or whatever are killing themselves because they can't be who they really are. So I'm giving that to you now in case you have somebody. I am going to do something on the Trevor Project, something that includes the Trevor Project, another video at another time. But I wanted you to have that information now because if the person is depressed because of their sexuality, and I didn't talk much about that because it's going to be its own subject in another video, but if they are have them call the Suicide Hotline or the Trevor Project. They're all 24/7. And you can text. You don't even have to call. You can text. So for the Trevor Project, it's 1-866-488-7386. Or you can text the word Trevor, TREVOR, to 1 area code 202-304-1200. And there's some online resources that you could look at. The American Foundation for Suicide Prevention has its own website, and and then there's one called the American Foundation for Suicide, and there's one called the Center for Suicide Prevention. Those are two different ones, two different websites you can visit if you're having problems with that and you need more information. But I hope that this has been helpful for you. I know it took a long time, but dag nabbit, there is a lot to deal with depression. It is very serious. I wanted to make sure all my points were being made, that if you're feeling depressed or someone you love is feeling depressed, that you can be there to help them. So I wanted to provide as much information as I could, and to empower you all to either get the help you need if you're the person who needs help, or get the person you love the help they need before it's too late. And being able to recognize what kind of things to look for. I mean, girls are always saying, oh, I could tell if my man's cheated, because he'll hide his cell phone and lock it and all this kind of stuff and all that. Well, you know what? Why don't you tell me when your man's depressed? Or if he has a drinking problem, or he's a drug problem. I don't really care about the cheating right now. I know that can cause women depression, so I'm not going to take away from that. But I don't want that to be like the focus, you know what I mean? So I wanted to remind you all of a few things. Remember, I'm a member of the National Alliance for the Mentally Ill, NAMI. It's called NAMI. And I am in part of the San Antonio chapter, but they have chapters all over the United States, maybe even internationally. I've gone to speak for them in front of hundreds of people from all over the world. I met people from London, England, Ireland, everything. It was cool. And it was there in Michigan. I had to fly to Michigan to do that with my boss. But anyway, look into NAMI, being a supporter of NAMI. They need all the help they can get. They're a grassroots organization, and they have offices all over the place. So they're national. That's what they call the National Alliance. And you can join at a low price if you are the one that's disabled. I don't know if they started charging, but they didn't used to charge. Me, I pay because I'm a professional member, but it's like $30 a year. I mean, and then what do you get? You get to attend all their general meetings, all their educational classes that they have, family classes, public speakers, experts in the field, and stuff like that. So you can get a lot. You get very involved in something like that. And then I told you about the National Institute for Mental Health. That's a good resource. But I also wanted to bring up, now I know I ain't no Dr. Phil. Dr. Phil don't have piercings, and he's got a PhD. I'll get mine. It's next. I'm just one step below. But I admire him a lot. And what him and his son Jay have done is they've created what they call Doctor on Demand. So if you watch Dr. Phil, then you've heard of Doctor on Demand. And I want to put that out there as a resource for you also. It's a app that you can get at the Google Store or download. And I don't know how the pay structure goes or whatever, how you pay, if it charges to your phone or I don't know. But you can find all that out when you call. But what you do is you download it, and then at any time you hit the button of whatever you're calling for. If it's medical, psychological, or both, or whatever, and it'll give you a board certified professional doctor that can come and talk to you on your computer, on your cell phone, or whatever. You never have to leave the house if you don't want to. And they are able to call in prescriptions and stuff like that if they deem they are necessary. So I mean, if you're going to be calling and asking for medications, you better be real sure that you can display a history of this behavior that warrants you needing the medication. But I wanted to throw that out there because I thought that was really cool. And I'm going to talk more about his wife's cause when I get to that topic, domestic violence. Robin has groups of her own. I can't remember what they call them, but organizations. Robin has organizations that she's created, and her number one thing is to combat domestic violence, empower women to not be victims, and things like that. And so when I come back and I'm doing my video on that, you'll probably hear more about it because I'll learn more about it myself. Thanks for watching. I'm sorry this took longer than I expected because I'm supposed to be going shopping right now. So, birthday gift for my cousins. But I hope you learned something. If you have any questions, please feel free to email me. Remember, you don't have to be my friend on Facebook or anything. If you have a question, you can remain anonymous. You can email it to me at dear_Tina88@yahoo.com. I check it every day. And I'll be glad to come on here and create a video specific to what your problem is. And, what else was I going to say? Oh, just basically that's it, I guess. See, I zoned out. I haven't had any caffeine yet today. I don't know what my cousin's doing, so I keep looking over there. But anyway, I hope everybody has a great day. Please subscribe and share. So many people need to hear what I've been saying, even if I did goof up a little bit here and there. I don't know, it's just it's who I am. Quirky, kind of quirky. So, quirky, dorky, it's all the same. Thank you. Love you all. Take care of yourselves and each other. And I'll see you at my next video. Bye.